Good afternoon, distinguished guests around the globe, and welcome to today's SafeCut International Exchange live broadcast. I am your host, Joyce. It is August 21st, 2025, and we are streaming from the Cardiac Cath Lab of Jiangxi Provincial People's Hospital. Engineered for excellence, SafeCut cutting balloon merges the high pushability shaft with a low-friction hydrophilic coating, delivering smooth, reliable navigation through the most complex lesions. Its ultra-sharp, directional blade enables precise control cutting, optimizing lumen gate while minimizing the vessel trauma. Backed by a dual-layer, non-compliant balloon design, SafeCut delivers outstanding crossability and high-tolerance burst strength. Soft on the outside for gentle tracking, tough on the inside for confident dilatation. Over the next hour, we will witness and discuss in real time the precise step-by-step application of the SafeCut cutting balloon in a heavily calcified coronary lesion. Guiding us through every maneuver is our featured speaker, Professor Qiulin Yin, Chief Physician of Cardiology and a world-renowned expert in complex PCI. Together, we will explore optimal lesion preparation, procedural best practices, and the rapid recognition and management of any complications. Now, please allow me to provide some context of the hospital and the team today. Jiangxi Provincial People's Hospital was founded in 1897. It is a large-scale territory Grade A general hospital integrating medical treatment, healthcare, scientific research, teaching, and physical examination. It is also the first Western medicine hospital in Nanchang area. The Department of Cardiology Medicine, as a characteristic specialty of the hospital, is a national key clinical construction specialty and a key medical discipline of Jiangxi province. Dr. Qiulin Yin, Chief Physician of Cardiovascular Medicine at Jiangxi Provincial People's Hospital. Professor Yin is a standing director of the Jiangxi Interventional Cardiology Society and serves as mentor to the cardiovascular interventional diagnosis and treatment technology base under the Health Department of Jiangxi Province. His academic record includes principal investigator leadership of 5 provincial health department research projects and 2 provincial science and technology department grants, participation in more than 10 provincial life science initiatives, and authorship of 5 CI indexed publications. In the cath lab, he has personally completed over 15,000 interventional cardiac procedures. With particular mastery in complex, high-risk, and calcified coronary lesions, his clinical reach extends to the full spectrum of cardiovascular emergencies, common, complex, difficult, and critical, making him an ideal guide for today's case and discussion. Now let's take a look at our patient information. The patient is male, and he's currently 80 years old. He has suffered recurrent chest tightness for about 6 months, aggravated with chest pain for 9 days. For his history of present illness, the patient reported experiencing chest tightness localized to the precordial area following physical activity, approximately 6 months prior, without accompanying chest pain, palpitation, or dizziness. No medical consultations were sought at that time. For his medical history, his general health status is fair. For his chronic conditions, he has hypertension for about 30 years. He has coronary artery disease and old myocardial infarction. For his admission diagnosis, he has coronary atherosclerotic heart disease, old myocardial infarction, heart failure, as well as the hypertension. In just one moment, Dr. Yin and his team will begin the live case demonstration and perform the coronary cutting balloon procedure. We invite you to observe closely and engage with any questions during the Q&A session to follow. Thank you for being here. I wish you all an enlightening and productive experience. Please activate your microphones and cameras. Your questions and observations drive this exchange. Professor Yin, the floor is yours, and whenever you're ready to begin the case.
don't see
来给张一杰
where and when he used the cutting balloon. In which vessel? The circ or the
Oh.
LED?
Okay, I think I would like to generally briefly introduce the whole procedure. So our target lesion is in LAD. So before we use our cutting balloon, the doctor has used the 2.0 millimeter NC balloon for the pre-dilatation. Then he used the IVUS to check inside the vessel, and the distal end is 3.0 millimeter, and the proximal end is 3.5 millimeter, and the calcification plaque is mainly in the left main area, and the target lesion, the calcification is in 360 degree. And then our doctor decided to use the 3.0 by 10 millimeter cutting balloon and inflated it to 10 to 15 atmosphere. So after using the cutting balloon, the doctor has reused the IVUS to check the blood vessel, and the proximal end's calcification has been properly treated. And then he used the NC balloon and inflated to 24 atmosphere. And the calcification located in 1 o'clock has been cracked. And the distal, the ostium has shown good patency as well. And there has been no dissection after the treatment. Then he used the MC balloon for the post dilatation as well. And after the post dilatation, he used the one stent to make sure there's less likely for the restenosis. And we used the IVUS to check inside the blood vessel, and we could see the very good stent apposition. So that is generally the whole procedure. So to answer your question, the target lesion is inside the LAD.
Okay, and just a question,
Yes.
because that will be a challenge for cutting balloon. But I would like to see if there's a difference with your cutting balloon. If we could directly, when we see that it's okay, is indication for the cutting balloon, but directly to use the cutting balloon instead first the NC balloon 2.0. So
Yes.
just to test the pushability and the profile of the cutting balloon, of your cutting balloon, that I would like to see, but it's
You
it's
mean you would
to
like to see the image?
no, not the image, but just to see, but just to try to use directly to try directly the cutting balloon instead first NC balloon,
Yes.
then cutting balloon. Because if you use first NC balloon, that you can crack the calcium for a part.
Mm-hmm.
Sure,
Yes.
not the all. Sure, not the all, but for a part that you have done some job. But what I would like to see the challenge of your cutting balloon, to use it directly without any preparation of the lesion, to see how is the profile of the cutting balloon.
Oh, I see. But for today's procedure, we have finished the procedure. So we will have following more safe cutting balloon live case. And we will see if we can do that in our next procedure. But for this patient, our doctor has finished the operation.
Okay.
Yeah, but do not worry, because we have merge the high pushability shaft and low friction hydrophilic coating. So it works very well. And to use the NC balloon is because the doctor has examined the patient's situation and decided that is for the best for the patient.
Okay,
But
just one situation.
yes.
In my meaning that if really
sure. I think I understand you want to see the pure result of cutting balloon without the use of NC balloon, right?
exactly.
Yeah, but
I
as I
mean
was saying,
before
for this patient, we have finished the procedure. We cannot just put it back into another vessel. But for our next patient, we will try and see if doctors will use the cutting balloon firsthand.
okay, just to test the the crossability of the balloon through the calcified lesion, because it's really important for us to know that the profile of the cutting balloon, of your cutting balloon, I mean, will be better as the other cutting balloon through the calcified lesion without any preparation. But I agree, if really the calcified lesion is not crossable with a cutting balloon, we have to predilate with 2.0 or 2.5 just slowly. But if it's possible just to try it without any preparation to see how is the result with any preparation and the profile of the cutting balloon through the lesion, because the profile of the cutting balloon is very important to know it.
Yes, I understand. Sir, please wait. I'll ask the doctor about the crossing file and the possibility. Is that all right? I'll ask him to answer that question.
Joyce，你翻译成中文一下。
刚刚那个客户的话，他其实最主要的疑问就是他想要了解到我们的切割球囊在不使用预扩的情况下，它的一个推送性以及它的一个通过直径，就是通过性怎么样？然后因为我们主任是有做一个预扩嘛，用2.0的预扩，然后
做了。
这位客户主要是想知道，就是如果说我们不用这个预扩的话，就是对我们的效果会是怎么样？我们的一个推送性和通过性大概是怎么样子？就主任您可以就是大概讲一下吗？
好嘞。如果说你不做预扩的话呢，要看这个病变的狭窄程度。如果说病变的狭窄程度如果在90%以上，你不做预扩，cardiac balloon 的这个通过性，任何一种 cardiac balloon 通过性都过不去的。所以说，在这个严重狭窄的基础上，我们常规要做预扩。如果狭窄在80%到90%之间，这样的我们这样的病人常规不做预扩是完全可以过得去的。然后可以做到很好的一个切割。这根据病人的这个狭窄程度，还有一个钙化的程度来进行决定。实际上我们原来也做了很多那种不预扩直接进行切割球囊的病人，通过性是非常好的。但今天这个病人就不一样，因为他第一个狭窄非常严重，第二个的话呢，我还是要看 IOS， 因为如果不预扩的话呢，我连 IOS 导管都过不去，而且会影响病人的血流。所以说我今天还是要首先做个预扩，一个是为了安全，第一个是为了这个切割球囊能更好的通过。谢谢。
好嘞，谢谢您。So the reason we use the balloon for the pre-dilatation is because for this patient, the calcification rate is above 90%. If the patient's calcification is like below 90 or from 80 to 90, then it is fine for us to use the cutting balloon in the first place without any pre-dilatation. But for this patient, because the calcification is very severe, which is the reason why we use the IVUS to pre-check the vessel wall. And for the purpose of safety, we did the pre-dilatation. And if the calcification for our next patient is below 90, we will try to do the cutting balloon for the first step. Thank you. Does anyone online has any more questions? Our doctor is here to answer them all.
Just a question for you, technical. Which is the right burst of your cutting balloon?
Sorry, right what?
Right burst pressure, the maximal pressure.
Oh, pressure.
Yes.
Okay, so for today's procedure, I think our doctors use the 10 to 15 atmosphere, but I will ask him about the preferred atmosphere. 主任您好，刚刚线上有一个人员他提出一个问题，就是说因为今天您应该是切割球囊用的是10到15个大气压，对吧？
对。
然后他说您一般就是都是用这个大气压吗？还是说有一个就是比较常用的大气压？
是这样的，它这个球囊的秘密压应该是6个大气压。我要根据我这个球囊的跟血管的直径比，如果我是选择1比1的话，我一般不会打得这么大，打6到8个大气压，我另外就会结束了。但是今天的近端的话呢，它至少在3.5以上，我选择的是3.0毫米，所以它的比值的话呢，还就是0.8比1左右，这个时候我就会打大气压大一点，会打了10到15个大气压，跟你选择的球囊的直径跟血管的直径比，这个很有关系的。
哦，好的，谢谢您。So our doctor has just answered. So for today's procedure, because the proximal end diameter is pretty big, it's 3.0. So doctor decided to use the atmosphere of 10 to 15. But if the target vessel, the ratio of the cutting balloon and the target vessel is 1 to 1, he would normally use 6 to 8 atmosphere. But for if the ratio is not 1 to 1, he would see the ratio of the cutting balloon and the target vessel and use approximately higher atmosphere to treat the target lesion. Does that answer your question?
This is just no. Just question. I have not finished the question. I mean, which is the maximal pressure that we can inflate your? It's for you. It's not for the doctor. It's for you. The technical. It's a technical thing. Which is the maximal pressure that we can inflate your balloon?
Oh, okay. Sorry, just one moment. 杨经理，咱们这个最大是打到30个大气压，对吗
22。
22是吧？好的。So the maximum pressure is 22 atmosphere.
Okay. 22.
Yes, 22.
Okay. Right. Nice. Okay. Thank you.
You're very welcome. So I saw the Hem International has posted a question. For 360 calcium IVO is recommended also. How can we compare IVO with cutting balloon performance in this regard? 这个可以问一下主任吗？就是主任如果之前有做过 IVO 的话，想问一下，如果360度环形的钙化的话，就是我们切割和 IVO 的那个治疗效果，您这边有比较过吗？或者您有一点见解吗？
好嘞。对于360度的环形钙化，特别是很厚的钙化，比如说大于0.5毫米的钙化，那毫无疑问 IBL 要优于 cut balloon。因为它的 balloon 它的切割的高度它是非常有限，我们这个是0.25个毫米，所以说的话不一定能把这个切开。IBL 它就很有优势，就它会通过冲击波的力量，大概可以达到50个大气压的一个力量冲击。这样的话呢，就是说可以更好的把这个钙化环打开。所以说对于这些房型钙化来讲，可能 IBL 要优于切割球囊。OK。
好的，谢谢您。So to answer the Hamilton Nationals question, so for 360-degree calcification, if the thickness is above 1.5 millimeter, it is better to choose IVO than the cutting balloon, because IVO can effectively treat the superficial and deep calcification. And when it is generating the sonic pressure wave, its atmosphere can increase to 50 atmosphere, which is always better than the cutting balloon. And it can open more lumen gain for our patient. But if it is superficial, then I think these two are the same. So I hope this answers your question. Does anybody online have any more questions?
Yeah, please.
Hi.
Hi, doctor. How are you?
Hi, I'm Joyce. I'm the host, but I will translate your words to the doctors.
Okay, my question is how the doctor recommend the cutting balloon in soft instant restenosis before using the DCB?
Sorry, could you please repeat your question? How would the doctor recommend the cutting balloon in the soft distal end?
No, in the distal soft tissue in instant restenosis.
Distal soft issue.
Yeah.
Before the DCB.
Before the DCB, yes.
OK, thank you for your question. 主任是这样，这个客户他有提问说，就是在远端的一些软组织的处理上面，就是我们在放置涂药球囊之前，您一般会去怎么使用切割球囊来做处理
？OK， 因为这个药物球囊的话呢，在放入之前，我们也要是充分的预处理。预处理越好的话呢，它 DCB 的效果也会越好。但是我们要把握一个度，就是说你不能把它处理的太过了，比如出现一些B 系以上的C 系以上的夹层，那就不能做 DCB 了。所以说我们对于这样的病变的话，我们就是选择切割球囊，我会小一个型号。比如说这个病人是2.5的血管，我可能会去选个2.0的这个卡利布鲁。这样的话呢，可能对这个 C 系以上的夹层的发生率会更少。还有的话呢，如果是支架内在狭窄的病人，那就无所谓了，因为它这个夹层的出现率是非常非常低的。好。
好的，谢谢您。So our doctor has answered the question. We will always use the pre-treatment for the DCB. It is always ideal, and to use the cutting balloon before the DCB at the distal soft issue. The doctor would normally choose the size slightly smaller than the target vessel's diameter. So for instance, if the target vessel's diameter is 2.5 millimeter, our doctor would use the 2.0 specification of the cutting balloon. This is to ensure that we reduce the likelihood of the dissection normally, but for the ISR situation, because we already have the stent inside the target vessel, so it doesn't matter if it is unlikely for us to cause the dissection, so we don't have to choose the smaller specification. We just use the 1-to-1 ratio. So like if the target vessel is 2.5, we just choose the 2.5 cutting balloon for the pre-treatment.
Okay, thank you.
You're very welcome. Does anybody else have any questions? Would our online guests be interested in the details of using our cutting balloon? 主任想请问您一下，就是可以从那个咱们使用切割球囊的它一个最终的性能，以及它比如说在使用过程中的一些优点，您能帮我们总结一下吗？
顺美的吗？
对，顺美的。
好的。我从使用顺美这个经验来看的话呢，就是说我也使用了很多其他品牌的这个它的 Blue。顺美的话有这几个优点，第一个的话呢，它这个通过性非常好，就是说它的柔顺性都挺好的，另外的话呢，就是说它从它的刀片的设计来看，就是说，第一个的话，我们是说3.25以下的血管，它都是3个刀片；3.25以上，它都是4个刀片。这样的话展开以后的话，我们所能切到的这个范围会更广。这样的话，切的深度会更好一点。还有的话，这个高度是0.25个毫米，非常适中的，也非常这个好。另外一个优点，它这个肥爆很好。肥爆性好的话呢，就是说它，我比如说我一个血管病变比较长，我要去切几个地方的话呢，就是说以便能够顺利的通过。特别是对于在一些钙发扭曲的地方，就保证了它的通过性。还有一个优点，它那个耐高压，由于它这个双凸层的设计，所以说它能够达到22个大气。其他的任何一款切割球囊是达不到这个压力的，一般15、16个大气是，它就是它的爆破压了，那就可以破的。这是我使用这个顺美球囊它的这些优点。好的。
好，谢谢您。So I just asked our doctor how he reviews today's Shumei's cutting balloon, our SafeCut cutting balloon. So to summarize, the doctor thinks the Shumei's cutting balloon has really good crossability. And because the target vessel is 3.25, normally other brands cutting balloon has 3 blades, but we have 4, which can reach more area of calcification, hence the better outcome for our patient. And the height is preferable. It's pretty good. It's 5.25 millimeter height. And because it has the NC design, which allows doctor to inflate the atmosphere to 15 to 16 atmosphere. These are all the attributes of our cutting balloon.
Just a question.
Yes.
How should we inflate your cutting balloon? Gradually or directly?
OK. 主任想请问一下，就是您在给我们球囊加压的时候是缓慢加压，还是说一次性就是达到15到16个大气压的？
切割球囊肯定是要缓慢加压，缓慢回撤。因为加压太快的话呢，可能这个球囊的优点就会失去。
好的。Sir, to answer your question, our doctor would suggest to inflate the cutting balloon gradually, because if you need to inflate and deflate both gradually, because if you inflate all of a sudden, the cutting balloon can lose its advantages, and it can be ruptured, I think. You're welcome. So we have our guest from Russia, I think, to ask us, do you have any clinical studies that confirm the quality? Yes, we are conducting our clinical trial right now. This is our first live case so far. We will do more in the future. Once we completed the clinical trial, we will post them online, make them public. 杨经理刚刚就是有一个客户，他有问到我们有没有临床的一些试验的一些结果，然后我跟他说的是我们的那个临床试验正在进行中，然后如果做完的话，我们会全部公开。
我们的临床试验已经入组完毕了，现在在随访阶段，是1个月的随访，目前在数据清理阶段。
Okay. A little update. So in about 1 month, our clinical trials result will be made public.
我们的临床试验是跟那个波士顿科学是做对照的。对。
Okay. So our clinical trial is the RCT, and we will be compared to the Boston's cutting bloom, Boston Scientific's cutting bloom. Okay. Does our guest have any questions for our doctors? Because this is a really precious time. We need technical for our doctors.
Thank you, nice job.
主任想问您一下，就是您有没有就是想要跟国外医生交流的或者问题，或者说有没有什么要嘱咐我们那个医生，比如说他们后续在使用切割球囊方面的一些建议或者见解，您可以分享一下吗？
我提的不多吧，我提一点就是说，当你切割球囊切完以后的话呢，最好能够看个 IVUS 这个 OCT。看完以后，如果因为钙化反打开的不理想的时候，这个时候你用一个后果种球囊去把它处理一下，可能效果会更好。就是切割球囊跟后果球囊有的时候要进行配合使用，这样的话可能够最大的发挥这个切割球囊的这个作用。因为我们里面单凭一个切割球囊要对付一些严重钙化的病变，可能需要各个手段的进行联合起来，也不能完全靠一个切割球囊可以把整个手术完成。OK，
好嘞，谢谢您。So the doctor has just gave us a recommendation in using the cutting balloon. So in his experience, after using the cutting balloon, it is always better to use an NC balloon for the post dilatation. And because if we rely on the cutting balloon alone to crack the calcification, the result might not be as ideal as we anticipated. That's why we always use the NC balloon for the post dilatation. And also, doctor has suggested we always use IVUS to check inside the blood vessel to make sure the calcification has been properly cracked. So that's one recommendation from our Dr. Yin. Thank you very much. Okay, so if we do not have any more questions online, I think this concludes today's stream. I would like to thank everyone who has participated in today's streaming, and thank you very much for your insight and exchange for the cutting balloon. and we will do more live stream of our SafeCut cutting balloon in the future. And I would like to thank Dr. Yin and his team as well. So this is the end of our stream. Thank you very much. 好，谢谢主任，我们那个手术直播结束了，谢谢您。
好的，谢谢，感谢各位专家啊。